Hi, this is Dr. Nick with the ECG Academy, and this lesson is on ventricular tachycardia. Now, we're going to be talking for the most part about monomorphic VT because that's what we generally see on cardiograms. It's fairly easy to recognize, but we're going to cover in detail what kinds of things you should be looking for. For the most part, ventricular tachycardia occurs when the electrical signal is going round and round in a circle at a rapid rate in the bottom chambers. Now, what rates? We're generally talking 100 to 120 beats per minute, depending upon which definition you use, and it can go all the way up to about 350, although from 250 to 350, monomorphic ventricular tachycardia is often referred to as ventricular flutter. On rare occasions, there can be a focus in the left ventricle or the right ventricle that's firing at a rapid rate and taking over the heart rhythm, but those are much less common, and we will cover automatic ventricular tachycardias in the advanced course. But for the time being, let's talk about the usual variety of ventricular tachycardia, and that's re-entry ventricular tachycardia due to a short circuit. Where does it come from? Most of the time, as this animation shows, ventricular tachycardia comes from a scar someplace in the left ventricle, an old heart attack perhaps, or sometimes the ventricle may be diseased diffusely because of a condition known as cardiomyopathy. And what can happen is short circuits in the left ventricular wall can result in delayed conduction, slowing of conduction, and this allows the development of short circuits in the heart muscle. Now what happens is a premature beat in the ventricle occurs, or maybe a couple of PVCs in a row, and the electrical signal gets stuck going round and round in a circle you can see here in the left ventricle. Because of a short circuit at the edge of this scar, the electrical signal has an opportunity to get stuck in a re-entry circuit, and that causes a very rapid heartbeat. Now notice what's happening in the atria. In this case, I've drawn it so that there's no retrograde AV conduction, and the sinus node is just kind of like firing at a regular rhythm, and that's how you can actually get a chance to see AV dissociation, which is what we call it when the ventricular rate is faster than the atrial rate, and the atria and the ventricles are beating independently of each other. So what's this going to look like? Well, remember, if you're looking for ventricular premature beats, you expect to see the ventricular beat start without a P wave in front of it, or you may see a P wave, but the PR interval will be too short to have conducted. And the ventricular tachycardia will get started, and it will look distinctly different from the underlying complexes because it's following an abnormal course through the ventricular myocardium, not using the Purkinje system for the most part. Pretty easy to recognize. It's the kind of thing that creates a sense of panic when the nurse looks at the monitor and yells, VTAC! Well, here's the first strip I want to show you. The first thing is, for those of you who work on telemetry units, please don't stamp labels on top of the QRS complexes because it makes it a lot more difficult for us to look at it afterwards. You can see there are regular narrow QRS complexes on the left side, and then you have a 4-beat run of this wide complex tachycardia. Well, in front of these narrow complex beats, you can see there's a normal P wave, and the PR interval looks to be about 200 milliseconds. Everything is fine. And then this starts. Now, the first thing you need to do is look to see how did this start? What's in front of this wide complex rhythm? And you have to look at this as, well, is this first beat a ventricular beat or is it some kind of APC with aberrant conduction? That will often give you the best clue as to what this is. Well, if we take a pair of calipers and bring it down to the P waves, we can see the P waves are going at a rate of just above 50 beats per minute, maybe 54. And the P waves march through pretty nicely. Well, what happens when we put our caliper on the last of the sinus beats is we see indeed that there is a P wave here in front of this QRS complex that looks exactly the same as this P. But what happened to the PR interval? It got shorter. Here, this PR is maybe about 240 milliseconds. This PR interval is only 160 milliseconds. The PR segment is missing. You can see a PR segment here very clearly. This PR segment is missing. So this P wave did not have enough time to reach the ventricles, and therefore this beat must have originated from the ventricles themselves. Now, of course, there are exceptions to that rule, which we'll cover later on, and the main exception would be some kind of pre-excitation, but without confusing the issue, 99% of the time, when you see a wide QRS complex with a short PR interval, then this first beat is a ventricular beat, and it's followed by 3 additional beats that have the similar morphology. Now notice it is rather irregular. There's a little bit of a warm-up associated with this 4-beat run of non-sustained ventricular tachycardia. It starts out with a rate of about 120, and it speeds up to maybe 165 beats per minute. But we see that commonly in non-sustained ventricular tachycardia. Now what happens if we move our caliper from this P wave into the middle of the tachycardia? We actually see a very interesting bump here on the T wave of this beat. And I think if you use your imagination, you can clearly see that this T wave looks a lot different than this smooth T wave, and that high-frequency little jiggle is likely the P wave that was inscribed in the middle of this run of ventricular tachycardia. Now, this is a little subtle, and I'll show you better examples of AV dissociation. But these P waves are kind of small in amplitude and sometimes difficult to see, plus this is a very short run, so it may not be the best example. But depending upon the patient's AV node and whether it's capable of conducting retrogradely, you may or may not see dissociated P waves or retrograde conduction, one or the other. Well, let's take the next example. Now, this is an impressive strip and would usually result in someone hitting the code button. But you can see there are 2 narrow QRS beats in the beginning, preceded by P waves with a normal PR. And then you have what looks like 4 beats right here. And each beat looks distinctly different from each other, as well as from the underlying complex. So what we have are 4 ventricular beats in a row. So this is polymorphic ventricular tachycardia. Polymorphic meaning the beats look different from each other. They have different morphologies. And that 4-beat run of polymorphic VT then gets stuck in a reentry circuit that immediately organizes into a monomorphic ventricular tachycardia, here at a rate of about 230 beats per minute. One's always tempted to say, well, is this truly ventricular tachycardia, or could it be some kind of AFib with aberrancy? That's always the controversy that arises. And the rule is, if you have a rapid wide complex tachycardia, always assume it's ventricular until proven otherwise. Statistically, about 90% of all wide complex tachycardias are ventricular in origin, that they're not supraventricular with aberrant conduction. So assume it's VTAC until proven otherwise. Well, how are you going to prove it? Well, the hallmark of VTAC is going to be AV dissociation, and that's what you really have to look for when you're analyzing a strip. That means you need to see P waves and QRSs that are not associated one-to-one. Now, how are you going to see P waves when you have these rapid, sharp QRS complexes? Well, the best place to look for them is in the smooth part of the T wave. And I think what you should be able to notice is that these T waves are very smooth, and then this T wave has a little bite taken out of it, and then this T wave is smooth, and then this one has a bite, and this T wave is smooth, and this one has a bite. And so there's this alternating pattern of smooth and sharp and smooth and sharp. And what this represents is 2-to-1 retrograde conduction up the AV node. So the ventricular rate here is 230, but the AV node is capable of conducting the impulses backwards at a rate of about 115. So what you have is a ventricular rate that's twice as fast as the atrial rate, and there is an association between the two, but it's 2-to-1. By definition, this is AV dissociation because the ventricular rate is faster than the atrial rate, and this allows you to make the diagnosis of ventricular tachycardia. You notice in the beginning you don't see it quite so clearly because there actually may be some winky back going on, but it's a lot harder to prove that on this rapid strip right here. The other thing that helps you decide that this is ventricular or not is that the QRS is fairly wide. It's about 140 milliseconds here, whereas the underlying QRS complex is less than 120. And obviously the QRS morphology is completely different than the underlying. But there are a number of rules that we'll get into in the advanced course when we talk about SVT with aberrancy versus ventricular tachycardia and how to recognize VT based on the 12-lead morphology. But for rhythm strip analysis, this is the kind of stuff you should be able to identify. These retrograde Ps and the presence of AV dissociation allow you to definitively make this diagnosis of VTAC. I think in general, people look for excuses to not diagnose VTAC. They're always making up some reason that, well, this might be AFib with aberrancy or something like that, because they're afraid of the consequences of giving a patient this diagnosis. It really does open up Pandora's box. But if you want to be an ECG expert, you have to be able to call it as you see it. And this is absolutely clear in my mind. But let's look at the next example. And this is actually a 12 lead of sustained monomorphic ventricular tachycardia. No one should ever try to call this SVT with aberrancy. There are a number of 12 lead morphologies that we can use to try to make this diagnosis. And just to give you an example, you have negative QRS complexes in lead 1, which tells you that the axis is going away from the left side. It's in here someplace. And having such a marked right axis deviation is one clue that you're dealing with ventricular tachycardia. The fact that this almost looks like a sine wave, you have this sinusoidal appearance to the QRS complex, is almost always a sign of ventricular tachycardia. If this rate was above 250 beats per minute, this would be a great example of ventricular flutter. Just think of atrial flutter as being rates of 250 to 350, so ventricular flutter has a similar rate. This sort of like sine wave monomorphic rapid tachycardia gets the name ventricular flutter in some circles. All right, the last strip I want to show you in this section is, again, this non-sustained monomorphic wide complex tachycardia that was originally read as atrial fibrillation because it does appear to be slightly irregular. There are longer RR intervals, about 150 beats per minute. Then it gets a little bit faster, up to maybe 160, 165. Then it tends to slow down a little bit over here, and it just is a little bit of a variability in the QRS complexes. But it clearly is wide and bizarre, and it's monomorphic because each one of these QRS complexes looks the same in one particular lead. And the key to making the diagnosis is seeing what are the P waves doing. So if we take our trusty calipers and put it on the P waves and measure the P to P interval, we can see that this QRS complex clearly started sooner than the P was expected to land, and there's no P in front of it. So that would make us think that this is a ventricular beat indeed. If we assume that there's a P wave in the middle of this QRS complex and move the caliper over, we don't see a P landing here. But let's carefully analyze what's going on between these QRSs, because that's where we'll see the AV dissociation. So you have this wide complex that we assume is ventricular, and this one looks exactly the same, except this T wave right here is very smooth, and this one has this very sharp deflection on it. That sharp deflection looks a lot like the atrial activity that we saw in the beginning of the strip. Well, let's keep analyzing. Here's a QRS. Now the T is back to being smooth. Here's a QRS, but now you have this sharp deflection on the ST segment again. And so now you can detect a pattern where you have a smooth T, and then a T with a P superimposed, and then a smooth T, and here, again, an ST segment with a P wave superimposed. And so we have the same pattern that we did with the other strip, except that it's much more apparent here. And that is AV dissociation with a ventricular rate that's a lot faster than the atrial rate. And we have 2-to-1 retrograde conduction up the AV node. And that gives rise to these P waves that follow every other QRS complex. So this is a really great example of AV dissociation. And that's what you should be looking for when you look at a wide QRS tachycardia. Well, we've gone over non-sustained and sustained monomorphic ventricular tachycardia. In the next video, I'll talk about polymorphic ventricular tachycardia, a very special kind of polymorphic ventricular tachycardia called torsade de pointe, and finally ventricular fibrillation. Well, this is Dr. Nick for the ECG Academy. Thanks for watching.